Thank you for this opportunity to present this abstract. This was a study that I carried out in Kenyatta National Hospital during my fellowship in the East African Kidney Institute. The title of the study was Acute Kidney Injury and Electrolyte Abnormalities among patients admitted with cholera in Kenyatta National Hospital during that year. I have no conflict of interest to declare. I was the main investigators, and I will acknowledge my my colleagues and supervisors towards the end. So if we all remember, for those of us who were in Kenya, there was an outbreak of cholera in 2017. Cholera is an acute secretory diarrheal illness caused by toxin-producing strains of the gram-negative bacterium, the Vibrio cholera. The bacterium is classified serologically into more than 200 serogroups. But so far, only the serogroups 01 and 0139 have been associated with large-scale epidemics of cholera in the world. The 01 is a current cause of the global epidemic of cholera. And the 01 is also classified into two serotypes, the Inaba and Ogawa, and two biotypes, the Elto and the Classical. Now, we know that cholera usually affects people in resource-limited settings where there's not adequate access to clean water sources. And as such, cholera is endemic in mostly in Africa and Asia. Now, in Kenya, cholera has remained a cause of severe diarrhea, especially in those areas with poor sanitation conditions. And since the year 2007, cholera cases have actually been reported in Kenya to date, almost every year, which is a trend that actually indicates that cholera is now more of an endemic disease in our setup than more of epidemics or outbreaks. Now, at the beginning of 2017, Kenya experienced an upsurge of cholera, and we had cases being reported in various counties throughout the year. It especially peaked from around May till November, December there. The Ministry of Health reported a case fatality rate of 1.2, and that was by around November of 2017. The samples that were tested in our national reference lab showed that the serogroup was the 01, and the serotype was the Ogawa serotype. So much of the epidemiology. Just to mention how cholera becomes significant to the nephrologist, we'll need to go a little bit into the pathogenesis. So the bacteria is usually acquired by ingesting contaminated food or water. Now, once this bacteria gets into the small intestine, the toxigenic strains produce the cholera toxin. Now, the cholera toxin is a potent stimulator of adenylate cyclase, and this leads to markedly elevated levels of cyclic AMP. And it is these levels of AMP that cause massive luminous secretion of fluid that is rich in electrolytes like sodium, chloride, bicarbonate, and potassium. And these are secreted in, such high volumes that they exceed the intestinal absorptive capacity. And it is estimated that the fluid losses in stool may actually go up to 1,000 mL per hour. And through the course of the illness, the patient may actually lose up to 100% of their body weight, meaning we're talking about a fluid loss of up to 50 liters through the course of the illness. Now, this fluid, like we said, is rich in electrolytes, and it is estimated that 1 liter of cholera stools usually has about 130 millimoles of sodium, 20 millimoles of potassium, 100 millimoles of chloride, and 45 millimoles of bicarbonate. And as such, the common electrolyte abnormalities that we see or expect in these patients is hypokalemia, hyponatremia, and metabolic acidosis because of the bicarbonate loss. Really, you'll see some hypercalcemia, hyperphosphatemia, and hypermagnesemia. And that actually depends on the degree of the volume depletion. Now, if with this massive fluid and electrolyte losses, if this timely treatment is not initiated, the patient goes into intravascular volume depletion. They have decreased effective circulating volume, impaired blood flow to the kidneys, and eventually end up in a prerenal kind of AKI, which again, if it is not corrected in time, progresses to a more severe form of AKI, which is acute tubular necrosis, which will have a much longer recovery period. The electrolyte losses in the stool and the vomit usually lead to abnormalities like the metabolic acidosis. The sodium loss will cause hyponatremia, but also further, contributes to volume contraction. Hypokalemia may lead to arrhythmias. So from a nephrology standpoint, cholera is actually, or maybe a fatal disease if volume repletion and correction of the electrolyte abnormalities is not, it is not done adequately and timely. These patients end up in a circulatory failure and death. Now, with that brief introduction, we come to the objectives of the study. So what we aimed to do in this study was to describe the frequency of acute kidney injury and the electrolyte abnormalities among these patients who were admitted in the cholera isolation ward during those months of the outbreak. These were the specific objectives, again, acute kidney injury, electrolyte abnormalities, and to have a look at the BUN creatinine ratios among these patients. We did attempt to do some association analysis, just trying to see whether we can pick a few predictors of acute kidney injury or death among these patients. This was a cross-sectional study, a retrospective review of records of the patients who were admitted with cholera between those months of the outbreak. We included patients admitted to the isolation ward with a diagnosis of cholera, either suspected or confirmed. And because the interest here was really looking at the acute kidney injury and the electrolytes, we needed for a patient to be included, they needed to have at least one recording of urea, creatinine, sodium, and potassium. Because of, how, it is difficult, like during this institutional epidemics, to get a patient's past records. So it was going to be quite difficult to know whether, if you see an elevated creatinine, is it an acute kidney injury? Is it a chronic kidney disease? Is it acute on chronic? So what we did was we tried to eliminate those patients who, from their history and from their records, had been known to have a chronic kidney disease, basically because we could not determine whether this was going to be a chronic or an cholera-related AKI. Patients who did records which did not have any of the labs done were also not included in the study. If there was a test confirming that this patient actually did not have cholera, that patient was also not included. So we included about 127 patients during that period. Majority of them were male at 67%. They were generally young adults with a mean age of 36 years. They seemed to present early with a mean duration of symptoms before presentation of about 2.1 days. They did not seem to have a long hospital stays. Majority of them were able to be discharged within 4 days. And as of the outcomes of this 127 sample, 94% of them were actually discharged from the hospital. 7 of them out of this 120 died, with an in-hospital case fatality rate of about 5.5%, which is actually, it is not a small case fatality when it comes to cholera. The common symptoms that the patients presented with was watery diarrhea, vomiting, rice, what's called the characteristic stool of a cholera, the rice water diarrhea, and some abdominal pains. Interestingly, most of them actually from their recordings from the cardiacs from the accident emergency, the first blood pressure recorded, majority of them actually seem to have blood pressures above 90/60, with just about 27% of them having low blood pressures. Now, I did try to separate between confirmed cholera and suspected cases. And the confirmed cases were about 48%, the suspected 51%. The reason we did this is because during an outbreak, it is actually not possible to test all the patients who are admitted with the characteristic symptoms. And actually from the Ministry of Health guidelines, it was not mandatory to test all the patients. What we're saying is that if you had 10 patients coming from one geographical area, all exposed maybe to the same source of water, and they're all admitted in the hospital at around the same time, then you may not need to test the whole 10 of them. You probably just test about 5 of them. And that, I think that is a common practice during outbreaks. So as long as a patient had constitutional symptoms of cholera and convincing geographical circumstances, that patient was classified as having suspected cholera. And there were actually more than half of the patients that we had. The test that was done was mainly the rectal swab. The cholera antigen was done in only 15% of them. The other interesting finding that came up during when we were looking at the clinical characteristics of these patients was that majority of them had very, very high white blood cells. They had marked leukocytosis, with 27% of them actually having white counts of more than 20,000 per milliliter. This could actually just indicate that cholera does actually induce a strong systemic inflammatory response syndrome. Majority of them again had elevated hemoglobins, very high hemoglobins going up to in their 20s. And 69% of them actually did have these high hemoglobins. This again could just indicate severe volume depletion with hemoconcentration. And the other thing that we found was that the platelets were actually within normal among most of these patients. Now, when we came to looking at the urea creatinine and the BUN creatinine ratio, which was really the first objective of the study, is that we found that at admission, up to 48% of the patients did have elevated urea, that is urea above normal. 64% of them had elevated creatinines at admission. This was the very first lab tests that were found in the patient records, and compared to the day that the patient was admitted, you'd see that these were labs that were taken from the emergency room or as they were being admitted. Now, just as there has been from literature a bit of I would say, raising concern about cholera patients in studies done elsewhere, that whereas you expect this to be a pre-renal AKI, these patients actually tend to have low BUN creatinine ratios. So based on that review of literature, I tried to find out whether that was the case among our patients. And it was indeed the case, such that you find what we expect in AKI is a BUN creatinine ratio of more than 20. That is after converting both into milligrams per DL. And what we found is that majority of our patients actually had either normal or low BUN creatinine ratios, with only a very small percentage having a high BUN creatinine ratio, which was a bit unusual and raising a bit of perhaps we need to explore this a little more. When it comes to the acute kidney injury among these patients, we found that 60% of these patients, 60% of them did have acute kidney injury, the KDIGO criteria for diagnosis of AKI was used. We were mainly relying on the creatinine because urine output, again, in the setting of an outbreak, was not really being carried out. It was one of the goals, but we were unable to get urine output recordings in majority of these patients. So we're basically using the serum creatinine and applying to the KDIGO criteria for the diagnosis of acute kidney injury. So 60% of these patients did have acute kidney injury based on that criteria. And they were distributed almost evenly between KDIGO 1, KDIGO 2, and KDIGO 3 stages, with KDIGO 3 having 39%. KDIGO 3 was basically, if you use that criteria, is a creatinine. It was coming to a creatinine of about 350 and above in millimoles per liter. Now, the other thing that we found of interest was that of these patients who had acute kidney injury, majority of them actually did have the kidney injury at the time of presentation. At the very first labs that were done at admission, they already had elevated creatinines, and a small percentage of them came with normal creatinines, but then tended to develop the AKI while they were or during the management. Of these patients who had AKI, about 17% of them did get renal replacement therapy. And a majority of them actually did not get or did not require renal replacement therapy. And, in our setup, all those who received renal replacement therapy, they received hemodialysis. No one was put in on peritoneal dialysis. Now, again, we looked at the time of discharge, the outcomes of these patients who had acute kidney injury. And what we found was that of those who were receiving renal replacement therapy, actually majority of them were still dialysis dependent at the time of discharge. A few of them we managed to stop renal replacement therapy, and just one died of those who had acute kidney injury and required renal replacement therapy. Of those patients who did not require renal replacement therapy, majority of them actually had gone back to normal creatinines by the time of discharge at 56%. 25% still had some elevated creatinine at the time of discharge. And there was a good number of patients, about 20%, who we did not have the creatinine at the time of discharge. So we don't know whether they recovered or, they went home with elevated creatinines. Deaths among patients who had AKI were 9.1%, and 90% of the patients actually managed to go home. So when we came to look at electrolytes, we were looking at the frequency of what is the frequency of the electrolyte abnormalities among these patients. Now, at the time of admission, we find that when it comes to potassium, 26% of the patients had a low potassium at admission, and about a small percentage actually did have a high potassium at admission. But we find that a majority of those who had potassium abnormalities had actually been corrected by the time of discharge. Hyponatremia was actually the commonest electrolyte abnormality at 40.2%, and a few patients had hyponatremia. Majority of the patients who had electrolyte abnormalities, they had been corrected by the time of discharge. Now, chloride, again, majority of our patients had, what happened was actually, majority of our patients were not actually getting chloride done at that time. They were doing mainly, when electrolytes they were doing was mainly potassium and sodium. Again, when it comes to pH and bicarbonate, very few patients got a BGA done, a blood gas analysis. So we couldn't really tell, we couldn't determine how many of these patients probably had low bicarbonates or had metabolic acidosis. But among the few that we had, all of them had low pH and low bicarbonate among the ones which were done. But again, the figures were really small. So we tried to determine some of the predictors of acute kidney injury. And, yes?
You can summarize now, your time is
okay. Up. Yes, I'm actually done. So what we found was that there was some significant association between white blood cell counts and hemoglobin. And we found that patients who had AKI tended to have very high white blood cell counts compared to those who did not have AKI, and also tended to have very high hemoglobins compared to those who did not have AKI. Again, this could just signify the relationship there could be the severity of the illness and the severity of the volume depletion. And the other thing we found was that patients who had low sodium at admission also tended to have AKI compared to those who did not have AKI. So in conclusion, the frequency of AKI in this cohort was high at 60.6%, much higher than the few papers that I was able to get mainly from Asia. And it is possible that perhaps as much as these patients were presenting within 2 days, maybe we need a little awareness so that these patients come at the very onset of the symptoms, because even at the time of the admission, majority of them had already developed volume depletion severe enough to cause AKI. Sodium, like we said, was the commonest, hyponatremia was the commonest electrolyte abnormality, and hypokalemia followed at 26%. And we were again unable to elicit bicarbonate and metabolic acidosis. The in-hospital case fatality was 5.5. Again, compared to other regions, even closer to home Zimbabwe, this was still higher than would have expected in a disease that mortality can be reduced to less than 0.5% with proper volume repletion and management of the electrolyte abnormalities. And the other issue was the unusually low BUN creatinine ratios in a situation where you're actually expecting high BUN creatinine ratios. This has been observed elsewhere. And really some theories have come up like, is it possible that these patients have such severe volume depletion, or the volume depletion happens so fast they get into ATN, reducing urea absorption? No explanations really. It's just a curiosity for more studies, perhaps to find out whether maybe the cholera toxin actually does contribute to urea and creatinine excretion. So in conclusion, acute kidney injury and electrolyte abnormalities are common among our cholera patients, and they significantly contribute to mortality and longer hospital stays. So it is important to increase awareness that perhaps we need to be more vigilant with our volume repletion, and also awareness that these patients present much earlier than they do before they have gone into severe volume depletion. Renal replacement therapy was only utilized in a small percentage of the patients who presented with acute injury. And the other thing is that we were unable to get bicarb and pH. Again, raising the issue of perhaps we need to raise awareness so that in the team that is managing this patient, to make our blood gas analysis part of the routine lab works that they do. And this would have been my recommendations, and I've mentioned them in the conclusions. Thank you. That took a little longer than I expected. I wish to acknowledge Professor Makligeo, Professor Kaima, and Dr. Lois Acheng for their guidance and support during this study. Thank you.
Thank you very much, Dr. Wangari. An interesting presentation. Any questions from the audience? I have one from Dr. Muturi about the renal sizes in those patients who left hospital still having AKI. Maybe I can extend that question. 70% of patients were discharged on renal replacement therapy. Those who are not on renal replacement therapy, I think 25% still had elevated creatinine. I just wanted to find out whether there was any attempt to follow up this patient. And can answer that together with Dr. Muturi's question about whether any renal sizes were done for these patients.
In a renal?
Renal sizes on ultrasound, maybe.
Oh, okay. Thank you, Dr. Wala, for that question. Thank you, Dr. Muturi, for that question. I would start by saying that this one of the weaknesses of the study was that it was a retrospective review. And we were actually catching this information when the patients have already gone home. And there clearly was no plan. It was not indicated in the records what was the plan at the time of discharge of these patients. There was no further evaluation of these patients. Once they recovered from the cholera, once they became asymptomatic, they would actually be discharged to be managed as outpatients. So one of the recommendations was actually to perhaps attach a nephrologist or just have a nephrologist involved in the management of these patients during these outbreaks when you have so many of them coming in at the same time. But according to the setup of Kenyatta National Hospitals, these patients went home with elevated creatinines who continued to come for dialysis. It is my hope that they were actually referred to be followed up in the low GFR clinic in Kenyatta National Hospital that runs every week. That is usually the usual discharge plan for any patient who has a reduced GFR. So we were not really able to do the follow-up of what happens to these patients once they left the cholera wards.